We have two presentations this morning, and the first is from Dr. Suzanne McDermott. She'll be talking to us from City University in New York, and she's one of the principal investigators for the MD-StarNet project, and she'll be speaking about signs and symptoms in adult myotonic dystrophy. Suzanne, I think you can get started.
Good morning, everyone. I'm Suzanne in New York City, but I represent the site in South Carolina where I lived for 30 years, and I am the co-principal investigator at that site. Today, I'm going to talk to you briefly about a study that was just completed that was entitled Groups of Signs and Symptoms in Adult-Onset Myotonic Dystrophy that really represent a lifelong accumulation of symptoms. Very often we hear about presenting symptoms, but this talk is really going to be about the whole clinical course that we observe when we do the surveillance for MD-StarNet. This paper was written by a number of people, including Nicholas Johnson, who's in the audience, and the next presenter. We had 3 physicians who were involved in the process of developing this paper. Emma Kafalani and Swami Venkatesh, as well as Nicholas Johnson, helped with the grouping of the signs and symptoms. And then we had a number of co-authors, including the first author, who is a student of mine. She's a PhD student getting her degree in biostatistics. So she did the analytic part under my supervision. I'm an epidemiologist. So just to get started, the background of this study, I think everybody in the room knows that myotonic dystrophy is the most common form of muscular dystrophy, with a prevalence of 2, depending on the study that you look at, 2 to 20 cases per 100,000. And we all know that it's a chronic multi-system progressive condition. And the classic symptoms that are associated with it are myotonia and muscle weakness, although we know that there is a progression, and as the person lives with the condition, new symptoms appear. So we also know that the signs and symptoms change over time, and that's why this particular approach, using surveillance, when we look at the clinical record backward in time, from the time the abstractors read the record, they're able to capture how long that person was in clinical care and code all the signs and symptoms that are observed. When we talk about DM1, which is what this presentation is about, we typically talk about, congenital onset, childhood onset, and adult onset. And here we decided, after a number of discussions, to look at adult onset as those cases that present after the age of 10. Of course, this is an adult disease, and so the mean age when genetic testing occurs in the literature, this is about the literature, is 33.4 years with a standard deviation of 12.5 years. And that represents a diagnostic journey for the individual of about 7 years. So from the time the first symptom occurs, there's a lot of differential diagnosis investigation going on, and that typically, on average, occurs during a 7-year period. But the objective for this particular study was to group the signs and symptoms for DM1 that present in the same person during the clinical course, whatever that length of time is that we can observe in the 6 sites that were used for this study. We were able to identify 228 records of individuals with DM1 from the MD-StarNet system, and I'll talk a little bit more about that in a second. We had 22 signs and symptoms, with average of people experiencing 7.5, more or less, during their clinical course. And we used exploratory and confirmatory factor analysis, which is a way to group signs and symptoms and sort of relabel the groups as things cluster together. The picture of the map is of the current 7 sites that are participating in MD-StarNet. But at the time of this investigation, the sites that were used were all of Idaho, part of North Carolina, the Piedmont section, South Carolina, Utah, and then 21 counties in Western New York and Colorado. And the people who were included in this study were people who were diagnosed from January 1st, 2008 till December 31st, 2016. Some of you have heard about MD-StarNet in the past, but some of you probably haven't. So I just wanted to show a slide about the surveillance process. So what each site tries to get a list of people who have codes in their clinical records, whether that's a hospital record or an outpatient record for myotonic dystrophy. And those records, we include more than we have to when we first identify people. We use some of the more general ICD-9 codes. And then our abstractors go out, sometimes electronically, sometimes in person, and look at the record to make sure it actually is myotonic dystrophy type 1. And then there's a abstracting process that it goes on. In some states that's done by nurses, others it's done by trained abstractors. They're highly supervised, and they code the record according to a standard form that every coder uses. And then there is a on-site review to make sure all the relevant data is collected. And then everything goes up to a national clinical review committee where the physicians, all of whom are neuromuscular specialists and neurologists, review the records to make sure the case is in fact DM1. And then also they make a distinction between probable and definite cases compared to those that are possible cases. Possible cases never have the laboratory confirmation, the genetic confirmation of the condition. So the arrow shows that those go back into the pool, and our abstractors look at them at a later time to see if in fact that kind of testing was done, and if there's more information in the record that might make that be re-reviewed to see if it's a probable or definite case. So the way the cases are initially identified, I mentioned, are through inpatient and outpatient records, but we really focus on neuromuscular clinics in most of the sites. South Carolina happens to be an exception where we don't have very strong neuromuscular clinics in our state. So we do a lot of investigation through the major hospital systems, and then we survey all the neurologists in the state to see if they have cases that we haven't picked up in the major centers. But we also look through hospital discharge data sets to see if there are other identifiable cases that might have been missed because either they're going to just primary care for their treatment, or for some reason they did not show up in one of our primary sources. We also look in some of the children's special health care needs systems and birth defect surveillance programs to find cases that weren't previously identified. We also look at the birth and death records to make sure that when we identify a case and then they disappear, we need to know if in fact that person is deceased. But we use the clinical classification of International Classification of Disease 9 and 10 to find the cases. We all know, most of us know that ICD-10 was more specific. It has a very specific code for myotonic dystrophy, whereas there's a more general code in ICD-9. But we do have trained abstractors who read the record. It takes them hours per case to fill in all the different variables that we're looking for. And in this case, they looked at the definite and probable cases in great detail. They also looked at the possible ones to make sure that those, in fact, did have incomplete information. We also identified patients that are asymptomatic or were misclassified as having myotonic. So the definite cases are those who have the genetically confirmed diagnosis and from themselves, from their own genes, or from a very close family member. And then they come in with all the signs and symptoms, but the family chose not to do their genetic confirmation. They already know that the father or the mother or the sister or the brother have the genetically confirmed diagnosis. PCR is used as the primary, and Southern blot is used as a confirmatory test. And as I said, the distinction between definite and probable is having that DNA analysis for the definites, and for the probables, there's the first degree relative has a diagnosis, and they have the symptoms and signs of myotonic dystrophy. So overall, we were able to observe 228 patients who were included in this study. The average age when patients reported the first signs and symptom in the clinical record was 34 years old. That might have actually happened earlier than that. Obviously, the standard deviation is 15. So some people were 19 years old, some people were 49 years old, but that's the age when the patient reported that sign and symptom. And we all know that reports aren't 100% accurate, but that's what was in the medical record. The age when genetic testing was done on average was 40 years. So there it's the standard deviation tells us is between 25 and 55 years of age. And 78% of the individuals in the 228 patients had a definite case assignment, and 13% of those did not have a known family history. So it was, a new, probably a mutation that was observed with the DNA analysis, but no other family member was known to have the disease. Among the 160 patients who had the CTG, DNA analysis, the median repeat length was 426. So on average, our patients were reported, or the records reflected 7.4 symptoms per person. And the figure on the right here is simply to show how many ways different records showed the symptom that ultimately got grouped together into one sign and symptom. So this is just one example of many where our physicians had to say, these are not unique, these can be bundled. So we did a lot of early work in bundling the signs and symptoms so that they made clinical sense to the physicians on this project. Some of the other symptoms, such as cognitive impairment, developmental delay, and respiratory insufficiency, were only present in a small proportion of cases. And I really want to point out here that we know that cognitive impairment is a symptom of myotonic dystrophy, but because we're using already, this is not a longitudinal study where we're enrolling people and then seeing what happens. We're looking back in time, and a lot of people weren't cognitively tested. So we don't know that the fact that they don't have the symptom doesn't mean they don't really have the symptom. It's just not available in the clinical record. So I think when you think about it, if you're disturbed by seeing that there was only a small portion of cases that had these three very important signs and symptoms, it might be just a function of the way we do our reporting of and surveillance. So here's a table of the number of people who had each of the signs and symptoms, and people repeat. So these are not unique. So the 180 people who have the myotonia also had many of the other, as I said, 7.4 symptoms per person. And these are already the grouped conditions. These are not the hundreds of signs and symptoms that were initially recorded. These are the ones that are already grouped. And you can see that goes from, a very high proportion of the population having these signs and symptoms to a much smaller group on the next page. But For example, cataracts before age 50, for all the 228 people, 39% of them had that, but we know some people weren't yet 50 years old when we read their records. So amongst those who were older than 50, we see that 31 or 44 or 45% of them had that sign and symptom. And here are some of the less common ones where you're getting into the 30s and 20s and smaller numbers. And at the bottom, you see the three that I previously mentioned as being quite small, only because they weren't recorded on the record, not that they absolutely didn't exist in that individual. We did factor analysis, which is a statistical method that usually gets done in two parts. First is exploratory factor analysis, followed by confirmatory factor analysis. So what it means is that at the first cut in the exploratory factor analysis, we look at things that are highly correlated, and we use a cut point of at least 30% correlation. Then we run it through a much more complex statistical package of confirmatory factor analysis that looks for very strong relationships between the variables, and some of the ones that we found in confirmatory don't stay in the continue to be found in the confirmatory factor analysis. But what happened was we were able to find three distinct groups of clusters of symptoms, and again, these are not presenting symptoms, these are lifelong symptoms during the time that they were clinically observed in our records during the surveillance process. So the first group had muscular facial weakness and myotonia. You can see very high proportions of people had in that group had both of those, had either of those symptoms. And of course, people fell into all three groups. People were not uniquely placed in group 1, 2, or 3. The question is, how many of the symptoms, in the first group, there's only 2 symptoms. In the second group, there's 8 symptoms. And in the third group, there are 5 symptoms. We're looking to see how many of the symptoms during that lifetime an individual had in each of the groups. So amongst the 228 patients, 63 reported having signs and symptoms across all 3 groups, which is a lot. And we know it's a multi-system condition, so that's, I hope, not surprising. But 16% had initial symptoms in the group 1 and 2, and only 8% had symptoms in groups 1 and 3. And the groups are named facial weak. I'll get to the names of the groups in a second. Okay, so here are the groups, but in the on the dark green, there's the name of the group that we chose. This was clinically decided, and it didn't come out of a statistical analysis. Under facial weakness, myotonia, you can see there's a number of conditions that initially were in the exploratory factor analysis highly correlated, but when we came to the confirmatory factor analysis, only facial weakness, trouble smiling, and myotonia were confirmed to be highly correlated. So many people fell into that group. In the skeletal muscle weakness group, there were 8 symptoms that were highly correlated, and all of those stayed in the confirmatory factor analysis. And the GI distress and sleepiness group, there were 5, and these also stayed in throughout the exploratory and then the confirmatory factor analysis. And I just wanted to also make a little aside that the GI distress group with sleepiness, you wouldn't think that the same mechanism necessarily physiologically affects GI distress and sleepiness, and we're not suggesting that it does. What we're suggesting is that people who experience one of those are much more likely to experience the other, not simultaneously, but during the course of their clinical disease. So think about these as things that don't occur together, but eventually show up within each of these groups. I hope that makes sense to you. And then we tried to just do a simple prediction of what resulted in having each of these grouped signs and symptoms, and really nothing about the person. So many people had the facial weakness and myotonia in group 1 that really there was nothing that predicted it other than repeat length. Obviously, the longer the repeat, the more likely they were to have that group of signs and symptoms. But a lot of the people, 68% of the people overall, had that sign and symptoms. So people were pretty much all, many of the people, more than half, were in that group 1, but they also could be in group 2 and 3, and most people were. But having a high score, having many of the group 2 weakness, skeletal muscle weakness symptoms was associated, again, of course, with having a higher repeat length, but also being male. Male was the only time in group 2, male sex was the only time sex came out as a predictor. So men are more likely to have symptoms in the group 2 of skeletal muscle weakness. Also being white and having an older age of onset made people more likely to be in group 2. And in group 3, the GI distress sleepiness group, the only thing that was more likely to occur other than the repeat length was being white, non-Hispanic white. So in conclusion, we just wanted to, we did this wondering if there was a sex difference in the categories. It turns out only in group 2 were males more likely to be included than females. So that group of symptoms tends to be more prevalent in men. The repeat length was not, was associated with, getting in any of the groups. It didn't distinguish between the groups. And that the symptoms within each group tend to show up. So if somebody has, starts out with a reasonably high score, having, 3 or 4 of the facial weakness myotonia group, I would say that they're likely over the course of their lifetime to show up with the other symptoms of the 8 symptoms that are in that group. And same with GI distress and sleepiness. Usually, if you have 1 or 2 of those symptoms to start with, it's more likely that you'll have some of the other 5 symptoms in that group. But, we really want to make it clear that there's overlap in the groups, and that because it's a multidimensional condition, people show up with symptoms in all groups. And the way you score them in each group is simply counting the number of symptoms at any point in time. So do they have 1 symptom in group 1, 3 symptoms in group 2, and 2 symptoms in group 3 when they start? And those scores where they start high tend to predict what's going to happen next. So that's my presentation. I assume there's a minute or 2 for questions. So thank you for coming, and I open the floor.
Thank you, Suzanne. We do have a couple minutes for questions.
Thanks, Dr. McDermott, for that very clear presentation. While we're passing the microphone, here's a quick one from Charles Thornton. Of the 228 patients, those are the ones who have definite myotonic dystrophy?
Probable and definite, yes.
Probable. Yeah, so I just was wondering how many people of the ones that you started with were excluded later on account of not having any genetic confirmation?
I don't remember the exact number that we started, but the 228 were the funnel down, the ones that remained in because they had definite or probable. We started out with probably 350, as I recall, but there were a lot of possibles. Or it wasn't even that high. It was closer to 300 at the starting point.
Okay. Yeah, I was just trying to get it. I was asking that just to get an idea of how many people who are walking around who think that they have myotonic dystrophy have never had a genetic test to show that they do.
Right.
Okay.
Yeah.
We have a question?
Shahinaz Gadalla from the National Cancer Institute at the NIH. So first, I want to congratulate you for this hard work. People who do not do epidemiology may not recognize how hard what you have done, but also may not recognize that we have a great limitation here in the US by not having what other countries have, the like national health systems, registries that you can dig in and, learn and do things. And that's why the study, with all the effort this group and you have done, the study is still small in number, 300 patients. So, but that really talks about how much effort you have to do here in the US to do those kind of studies.
Right.
My question to you is, clearly a lot of the signs and symptoms you have looked at do not have ICD codes. So most probably there was a list of signs and symptoms of prior knowledge, and we didn't have a chance, you as a team, to look agnostically at other signs and symptoms that we don't know about, or perhaps didn't appreciate. So for example, we have not appreciated cancer in those patients for long years until this community came and said something, and we were able to tackle the right resource to look at it. And definitely very unfortunate, the right resource was not here in the US.
Yes.
Also, you weren't able to look at differences. Despite the fact that those are all adult myotonic dystrophy patients, there are clear differences by age, right? So for example, the group that is late onset have very different signs and symptom profile than the group that is, the young adults or the classic DM. So yeah, so things, for example, that this study haven't picked up, I'm not going to say cancer because cancer is rare. And we know it's around 5%, despite the fact that the risk compared to the population in certain cancers is 8-folds and 10-folds. So it's very, very high risk, but the prevalence is rare. Rare
Right.
in dystrophy, rare in the general population. But for example, diabetes, type 2 diabetes affect 8% of those patients based on our studies from the UK. We're not able to be backed here. So, again, it's great work, but you are limited by what we have.
Yeah, and I 2 points I want to make about what you said, and I really appreciate what you said. One is that there isn't a drop down or a list of the coders didn't have a checklist of already assumed to be signs and symptoms. They took the actual script, whether it was EPIC or what, depending on, what EMR they were looking at. And sometimes when we went to some of the clinical sites, it was actually paper, but they wrote down what are signs and symptoms. They're highly trained abstractors. They know what they're looking for, and they could distinguish between a sign and a symptom and a comorbid condition. And let me just say that our intention next is to look at comorbidities, because as you said, that's another very important feature of this. What is there a higher risk? I'm an epidemiologist, that's my field. Is there a higher risk for, as you said, we know it is for cancer, we know diabetes. We want to discover other comorbid conditions that occur in this population at a different rate than in the general population, even if they're rare. So that's still to come. This was a focus on signs and symptoms, not comorbid conditions, which I know are different things.
Hi, this question is from Mary Leishak. In addition to the comorbidities that you'll be looking at, what are your other next steps for using this information?
We have lots. There's a poster downstairs. I don't know if it's upstairs or downstairs, but at the presentation that one of my colleagues from Utah is giving about our look at injuries amongst people with myotonic dystrophy. The premise of that, the motivation for that study was that we thought prior to the actual diagnosis, people were having injuries during this 7-year lag period when they're trying to figure out what's wrong with me. We wanted to see if there are injuries associated in that lag period, as well as what kinds of injuries occur after diagnosis. So we're looking at injuries as another, important factor. I'm one of many investigators in the MD-StarNet group, and other people are looking at myotonic dystrophy. So Nick Johnson, who's going to talk next, not about MD-StarNet, but, he's been involved in a number of the studies that focus on myotonic. So he might be able to add to what I just said.
Could I just, I'm afraid we've got another hard stop this morning.
Sure.
That was great. Thank you so much for your presentation, Dr.
Okay.
McDermott. And
Sure, and anybody can email me. You can Google me and find my email address if you haven't written this down. But I'm happy to answer any questions or talk to people individually. Thank you.
Thank you. And our next presentation is from Dr. Nick Johnson, who's the director of the Myotonic Dystrophy Clinical Research Network. Sorry, I didn't notice that this was a dual presentation. Also from Dr. Statland at Kansas University Medical Center.
Yeah. Oh, okay. All right. Thanks, Charles, for having Jeff and I up here. We're going to close out the professional track with a little potpourri of natural history data from both adult and pediatric studies. And these are our disclosures. And as a reminder, these are the Myotonic Dystrophy Clinical Research Network sites as they stand right now, with sites across the United States, Europe, and New Zealand. And so the first thing to really kind of kick us off, and I'm going to turn it over to Jeff in a second, is, what have we learned from prior studies? I think, the summary, we'll start with the summary, which is that myotonic dystrophy is a extremely heterogeneous disease with variable progression, and we can document change using standard functional and strength outcome assessments. But one major question that remains, and both Jeff and I will talk about, is which assessments are most sensitive to progression in DM1, and can we define multi-center variability for power and sample size planning, because that's so important for effective clinical trials. Can we train evaluators in a multi-center study to obtain highly reliable data, and can we achieve acceptable retention over longitudinal study? So I'm going to pass this off to Jeff.
All right, I'm going to talk about the first Myotonic Dystrophy Research Network study. It was a 6-center study. It's already completed. It was a 12-month observational study at 6 sites in the US. The visits were at baseline, 3 months, and 12 months. We had 114 individuals who enrolled in the study. 95 of them completed the 12-month visit for retention of about 83%. We had a pretty good idea why most of these individuals didn't complete the study, because the Ionis clinical trial started about halfway through the conduct of the study, and many of our participants elected to enroll in that interventional study. All right, included, we had individuals with a clinical diagnosis of myotonic dystrophy, which is confirmed by genetic testing, diagnosed before 10 years of age. They had to be adults, able to complete a 6-minute walk test without support. And for this study, we included no symptomatic heart disease or pacemakers. The perception was this trial was really preparing for early phase studies, which at the time we thought were unlikely to include those participants. Of the 95 individuals who completed the 1 year, the majority were women. They spanned the adult age range, but the mean was middle age. There was a 7-year lag between symptom onset, which was in the mid-20s, and the age of diagnosis, which was in the early 30s. Looking at the muscle impairment of these individuals, they really spanned the full range using the MERS from 1 to 5. When you look at what we collected manual muscle testing. This included 13 bilateral muscles, or 26 total muscles, quantitative myometry, which included 14 total muscles and was presented as a normalized predicted of normal. In terms of functional measures, the 6-minute walk test, the 30-foot go, the time to distend 4 steps, a timed up and go, and then not shown here was a sit to stand 5 times as a measure of fatigue. And then forced vital capacity was both seated and supine. You can see the normal values presented here to put this in reference. And so our population in general was moderately affected on most of these measures of motor function. Looking at the change in strength at 1 year for manual muscle testing on the left and quantitative myometry on the right, the first thing to notice is there was a small but statistically significant detectable change in the total strength between 1.5 and 5%. If you look at the p-values, the precision of that estimate was similar regardless of the technique of strength testing, but the two are not directly comparable. So the change in manual muscle testing did not correlate to the change in quantitative myometry. Looking at the proximal versus distal, there was really no difference except in QMT, but this is a little deceptive. I'll show this on the next slide as there was only one distal muscle included. And in terms of upper and lower limbs, the change in strength was largely driven by changes in the upper limb musculature. This is showing you the change from baseline in the muscles tested with quantitative myometry going from the distal lower extremity on the right to the proximal upper extremity on the left. In green, you can see that trend towards larger changes in strength as you move proximally in the upper limbs. The most sensitive single muscles to change over a year were elbow extensors and the knee extensors. When we look at the change in the functional motor tasks, again, you can see a small 3 to 4%, but statistically significant change in the number of measures, typically which are either assessing burst performance or more proximal musculature. The time to descend 4 stairs and the time go 30 feet were items where a number of people lost the ability to do those tasks over the course of 1 year. You can change those into the velocity of performance and regain those values, which will give you some increased precision to see change. We saw no changes in the 6-minute walk test. Looking at baseline characteristics that predicted change, only the lower extremity muscle strength predicted the change at 1 year, and it had a very small prediction where stronger individuals tended to lose more strength, but this would need to be confirmed in a larger cohort. By far the most sensitive functional measure that we saw in this study was the change in the supine forced vital capacity. You can see it plotted on the y-axis here. Each of those arrows represents an individual's trajectory over that 1 year period, and the x-axis is their age. You can see the majority are losing function, but you can see arrows going up and down across the age range and across most of the baseline functional performance, with perhaps a window towards more consistent decline between 80 and 40% of predicted. This is largely driven by the supine FVC, which is typically thought of as a measure of diaphragmatic involvement. And you can see that here by looking at the difference between the seated and supine FVC, and you can see that gap getting larger over the course of 1 year. Takeaways from the study, DM is a heterogeneous disease, but we could see small but significant changes in a variety of measures at 1 year, and we were able to get reliable measurements in a multi-center study. Looking at modeling on a time functional measure, you can see a scenario where performance at baseline might help you select for a group of people with a more consistent change over the next year. You can see people who have normal performance, which would be a lower number here or in blue, are less likely to change over a 1 to 2 year period. People who are moderately affected may have a more consistent change, and people who are severely affected may lose the ability to do that. And I'm going to turn this back over to Nick to go ahead and close up and go to our next study.
All right, thanks, Jeff. So I think that that study was extremely informative, but also really, scratched the surface at understanding the variability that we saw in some of those clinical endpoints. And so there is an ongoing study called NDM1. This is a 700 patient projected enrollment, 2-year study at 16 centers at the DM sites. The original sponsors are the FDA and Myotonic Dystrophy Foundation, but now supported by this pre-competitive collaboration. And we have a new pediatric natural history study called the Aspire DM1 that has started to enroll. And so the goals of the NDM1 study are to characterize the disease severity and progression over 2 years in a large cohort with 700 patients. Again, to kind of provide the actual data for that modeling graph that Jeff showed in his last slide, the basal level impairment that predicts the risk of subsequent progression, to complete the development of a muscle RNA alternate splicing as a biomarker of DM1 severity, and of course, to provide robust natural history data to support drug approvals. So it's a pretty simple study. You have to have myotonic dystrophy and symptoms of myotonic dystrophy, and you have to be an adult. That's pretty much it. You can't be in another therapeutic trial, pregnant, or have other significant medical disease. This, at our last data cut, these were the current demographics of the patients who participated. So we're doing pretty good in terms of our enrollment of males and females. We're making efforts to diversify our enrollment. You can see there it's predominantly Caucasian. And then again, predominantly a pretty well-educated group with college or professional degrees. At the bottom, you can see a histogram plot showing the age of symptom onset and the age of baseline visit. And so you can see on average, participants have an age of onset of about 25, but I'll call out that we did not exclude individuals with congenital childhood onset in this study. And so you can see, within a subpopulation that there's some people in there that have a very early age of onset. The age of the participants currently is about, like I said, 43, but a pretty good distribution. And we just crossed 300 patients enrolled. So this is the plug to for the new sites that are coming on. We'll get you up and active. And then if you're doing the study, please keep enrolling participants. So I think at the end of the study, I'm optimistic that we're going to have a robust natural history data set that will really inform how to do clinical trials in myotonic dystrophy successfully and provide good data. I'm going to turn to something that we have to do a lot more work on, which is the pediatric forms of the myotonic dystrophy. If I can figure out how to use them correctly. So this is a picture from my MDF fellowship. It was a few years back, where we did a survey of adults who had children with congenital or childhood onset myotonic dystrophy. And this is looking at a range of symptoms and how impactful those symptoms were at that current child's age. And so you can see this kind of triphasic period first appeared in that symptom or in that survey. And it's hard to follow all of it. But I think when I think about congenital myotonic dystrophy, I think about the early infant period with respiratory failure, feeding difficulties, clubfoot, and hypotonia. Those symptoms naturally seem to improve, and childhood is marked by intellectual impairment, autistic features, ADHD, and GI issues. And then sometime in adolescence, the adult features of the disease present themselves. So we've done several now research natural history studies in congenital myotonic dystrophy, always using roughly the same criteria. So they had to have symptom onset, require hospitalization, require breathing assistance, feeding assistance, clubfoot, or hypotonia. And you can see we have a very modest CTG repeat length cutoff. And some of the data I'm going to show you is taken from this original cohort here with 50 children with congenital myotonic dystrophy who've now been followed for up to 4 to 5 years. But you can see the mean duration of respiratory support at birth is about 25 weeks, but varies between 1 and 156 weeks. And there were a number of these children who had ECG abnormalities during the course of the study. If you look at the demographics, you can see the mean CTG repeat length is about 1,200, but was fairly variable. And so looking at the grip strength, pinch and grip strength, you can see that, as opposed to the variable nature of progression in adult onset myotonic dystrophy, one of the unique features of congenital myotonic dystrophy is that all children have the same age of onset. And that does seem to play out if you can capture the outcome measure reliably, in the sense that if you look at the pinch strength or grip strength and look at these individual vector plots of children, they seem first of all, quite closely tied together. And then second of all, you don't see a lot of change, particularly in that early childhood. You do see a fair amount of dispersion that starts to begin to happen after the age of 8 to 10. And when I wrap at the end with our muscle biomarker work, then you'll see why that might be. This is looking at, so those were grip and pinch. This is a 10-meter walk, run, and then 6-minute walk. And so you can see here, the 10-meter, again, some natural improvement in that score. So lower scores better. And then it does seem to, fairly flat during that kind of middle childhood and then into adolescence. And then the 6-minute walk, here's looking at the total distance in meters, and the kind of gray circles behind are healthy controls that are taken from Josh Burns' 1,000 Norms project. So you, again, in terms of gaining distance, you can see, even though they start a lot lower than the healthy controls, they do gain motor strength and then seem to what looks like plateau after the age of 10. So kind of part and parcel with this is this question about whether or not, what's the underlying biology? We've talked a lot about RNA splicing and how important that is. And so when we started to look at this in children with myotonic dystrophy, there it is. Okay. The computer is going to be an issue. So the participant demographics here. So these are muscle biopsies that are taken from 36 children with congenital myotonic dystrophy, roughly speaking, equal in age between, equal in gender. And then you can see the age range of those muscle biopsies from, just 2 months of age to 16 years. We use 22 control DM1 adults, and then pediatric controls and adult controls as well to compare them. And this it's been accepted at HMG. But the punchline is in this slide, which is looking at Eric's MBNL inferred score. So this is kind of an aggregate measure of RNA splicing, with 1 being normal and 0 being not. And you can see the age of the children there taken, the age at which the biopsies were taken here. And you can see that in the CDM cohort, they really break into 4 groups. So early on in childhood, again, when you kind of think about that very severe infant period, you can see that there's severe missplicing of MBNL regulated events. In a cross-sectional way, if you look at children in the childhood period, you can actually see that in some cases their MBNL inferred RNA splicing is pretty close to normal. And then after the age of 8, you see that dispersion occur looking at the RNA splicing, just the same as you do when you look at their clinical outcomes. So you can see some of these children seem to have quite severe missplicing, and that actually matches where they sit in terms of their 6-minute walk or other features. And some children seem to actually retain a pretty normal RNA splicing pattern. And to top it off, even though this is all cross-sectional between different individuals, there are 2 individuals that did have repeat biopsies. So this boy here had a biopsy, and then again, this is his second biopsy now 8 years later. So you can see that he naturally had improvement in his MBNL inferred score. And this girl here had a biopsy and then had another biopsy here, and actually has held pretty stable over that time period. So I think this is our next big challenge, because we'll want to see these same exciting therapeutic trials come into children with myotonic dystrophy, but we have a fair amount of work left to do, and probably will not be doing a 700 patient congenital myotonic dystrophy study, but we do have a 50 patient study that's launching, focusing primarily on this group of children in this age range, to better understand, because the sampling in that range was quite sparse. So with that, you slide contributors, Charles, Ami, Kate, Melissa, and Kellen, of course, our investigators, and we'll take questions.
Hi, great talk. I was wondering, you kind of mentioned it for the congenital and childhood study, that repeat size was pretty modest. Were there a large portion of the children in the study at that lower repeat range? I mean, when I think of congenital myotonic dystrophy, I think of much higher repeats.
Yeah, so I'm sorry, I should have said, so the cutoff, for the exclusionary criteria was very modest, but you saw the mean CTG repeat length was over 1,200. And so I would say it was a handful of individuals who had a repeat length between 700 and 1,000 in the blood, but most of them, well over 1,000. Yeah.
Awesome. Thank you so much.
Can you? I think we've talked about this, but I don't remember what was the splicing scores of the normal children at particularly at how does it compare the normal versus the DM?
Yeah, that's a good question. And so the children were age matched, but by and large, their splicing scores were, above 0.8. So it appears that that fetal isoform transition, because I remember we talked about this a while, did that happen sometime over childhood? Probably not. That fetal isoform transition happened sometime before age 1 month.
Thank you both for a great talk. Given the data in the adults showing greater change in moderately affected adults, do you think about, in terms of recruitment for adult clinical trials, there's always the tension of you want to get the patients who are just diagnosed so they don't develop a lot of symptoms on treatment versus recruiting patients who are already moderately affected so you can show improvement. Do you have any kind of insight into what you would recommend for adult trials in terms of what kind of patients to recruit?
Yeah, I mean, I think currently we're sort of recommending people who are affected but not too severely affected. I think in terms of the size of change, you may see larger changes in people who are more affected in some areas, but the problem is the ability to keep performing the task may be compromised. You tend to get a sort of the best ratio of change to just the variability, I think, in that intermediate group right now. And the only risk with very early affected is they could stay very stable over the course of your trial.
Hi, this question is from Mary Layshock. Regarding trying to increase diversity in the sampling, do you know what the overall demographics for education, race, and ethnicity are? And then to follow up with that, how will we know when we have a good and correct representation of the population?
Yeah. Well, I'll say I know the answer. And, we probably could have done better at getting a sample with more diversity, but the question in terms of underrepresented populations is going to be sort of how many are there and how do we reach them? And so the population for adults were largely Caucasian. In terms of education, there was a mix with about 30% going on to college or more advanced education. And I'm not sure in your younger
Yeah, I
and
think
in the NDM so far.
in NDM1, we do have some of the demographics there. So, I mean, I think a couple things are worth noting. So in the genetic prevalence study that was done on the 50,000 newborn blood spots from the state of New York, for those samples that did demonstrate a repeat expansion off of the SNP chip, there were no individuals of African ancestry that were positive. There were some from a mixed American and then predominantly European ancestry. So I think we are likely to have a challenge should we seek to meet kind of, this appears to be a little bit more prevalent in European or Caucasian population. So but it's not non-existent in other populations. So I think it's unlikely we'll be able to meet US demographics, but I do think that we can certainly do better and continue to engage individuals. That does speak to, we know from other studies that individuals of underrepresented minorities tend to not participate in research as well. And so we want to make sure that we're getting individuals into studies. That's why we have so many sites all over the United States. Eric had a question.
Thanks both for doing this really important work. You probably get this question all the time, Nick. Any clues about what distinguishes that trajectory for the CDM kids that stabilize and the ones that decline? And is that, you'll probably find out in the larger cohort, but are there ways to leverage that for, study selection?
Yeah, so that's a very active part of our investigation, as you might expect. If you look at the individual at the time of the muscle biopsy, their physical function was distinguishing. So you could pre-select individuals based on, say, a 6-minute walk or 10-meter walk and try and capture some of that separation. There are interesting gene expression changes that occur, particularly in that lower subset that are part of our upcoming R1 application. So so we'll see if we can figure out what the mechanistic response is, but you can identify them a little bit based on their physical characteristics.
One more question?
Okay, I'll be quick. For the pulmonary testing, I was really interested in that. That's, one of the inclusion exclusion criteria that's often used in other disease states, and the noise in it. Is there any pattern with progression or improvement or stabilization with nighttime NIV use? And did it matter whether they used a mask or a mouthpiece for test-retest reliability? Was there more test-retest reliability difficulty in this population than we see in other populations?
Yeah, so a few things. I don't think we've looked in that original cohort at nighttime use of NIV, and I'm not positive it was collected. And I'm looking to Charles to see if he remembers. But so that was a missed opportunity. I believe it's been collected in NDM, so we'll be able to address just that issue. In terms of reliability, we didn't have a day 1, day 2 testing on this. What it was there was a 3-month time point, and so you can look at your consistency across there. For the seated, measurements, it was just 0, so it was the same value. For the supine measurements, it actually changed at 3 months, so it dropped by about 1%, and then by 12 months by 4 to 5%. So it appeared to be following a linear trajectory. So my feeling is it's probably was a real finding in this population, but again, having this follow-up cohort is going to be important to really understand how to break those out. And the values are only moderately impaired, right? So these patients overall were just below what we would consider the lower limit for normal testing.
Great, thank you.